My name's Mary Sharp. I'm a family practice physician with a 23-year-old son on the spectrum. I have been watching what goes on in the state for a long time, have participated with differing levels of success with parent advocacy groups. About 3 years ago, I read this article about the Autism Alliance of Michigan, unprecedented collaboration. And I thought, geez, that's exactly what we need in this state, because we really don't have an effective statewide advocacy organization. I've met with some of your leadership at the Kent Autism, it's AAS.
Autism Support of Kent County.
Autism Supports of Kent County. Some of their leadership in Mid-Michigan, we have a group called Mid-Michigan Autism Association that tries to sponsor interesting advocacy information and is working on a number of initiatives. So I've been involved with that, and then have been involved with the Autism Alliance. And the importance of having a nonprofit entity that is looking at the big picture statewide. I've always known that theoretically you needed that, but I've really had a chance to see it from the guts, inside out this time. And the legislation that was passed in March would not have passed without the leadership of the Autism Alliance of Michigan. We're new, we're young, we're little, so I actually got hired by them because I talk a lot and fairly loud. Calley is our CEO. She's also just been appointed as the chair of the governor's recently released Autism Council, and that has 12 people on it, different representations from the different state departments, the Department of Community Health, Department of Human Services. We have a young man with autism on it. There's fabulous leadership from the department, from the community mental health community. So I'm very excited about that. They wouldn't have anything to do if it wasn't for the work of Amy Matthews, who's at Grand Valley State University. And I'm hoping that some of you are familiar with Project START, which is the network that is trying to implement evidence-based services throughout the education systems in the state. Now, it's completely voluntary whether you participate in that, but the more parents and families know, the more they start asking questions. This is how leadership in the different school systems starts to get the hint. But if you have kids that are being mainstreamed or in centers or variations, you want your school district to be trying to implement the START principles and being educated by the START protocols. And you got it. Grand Valley State's right here, you guys. So you should be talking up START. Go to the Grand Valley State website and look up the Autism Center, and you'll read. I think it's a pretty nice website. So Amy Matthews several years ago recognized that we needed to have a state plan in the state. Bunch of federal funds that were granted in Combat Autism Act that just got reauthorized by President Obama like a year ago. A state can't apply for those funds to do research if they don't have a state plan. Well, Michigan has had some other problems that have been distracting our leadership, and we didn't have a state plan. Anyways, Amy Matthews, this incredible academic, elegant, smart woman, convenes a group of people to write the state plan. We spent 3 years writing it. It's really a good document. It's supposed to be available online now, but that's what we keep hearing, but I don't think it is available online yet. But it's a careful evaluation of what the different departments, leadership in government, Department of Community Health, Department of Education are doing, what the status of the individuals with autism that they are called on to serve. And it's not a great picture. And I've lived a life with a 23-year-old. I know about the stuff that has not been in place. The future's very, very different. And I think this state is about to leap from being one of the 10 worst states in the country to being one of the 10 best states. So Amy Matthews, Grand Valley State University, convened the plan. The plan is about to be publicly released. It's a blueprint of what we need to do in the state to fix things. The Autism Alliance of Michigan has developed as the private nonprofit partner to work with state departments to get this stuff whipped into shape so that when your kids become young adults, transition is not going to be a chaotic thing. It's going to be seamless. You're going to have people who are so informed on what the best programs are to help your kid learn how to get his job. There's just been wonderful leadership in the state in the last few years, and I think things are about to blossom. So I am very excited to introduce Dr. Calley Allen. She's a doctor, speech and language pathology. She's the former head of the Autism Center at Henry Ford. She's now our CEO. She was actually one of the people who developed the legislation that was just passed. The legislation isn't perfect. You know what? This is life. Nothing's perfect. But it's pretty dang good. We also, for your information, are one of the first states to be having our Medicaid-served population covered with an autism benefit. And that's groundbreaking. That's 40% of the kids in our state. So 40% of the kids that, so of that 40% of the population, the kids with autism are going to get the same quality, evidence-based services that kids with traditional insurances are going to get. So that's pretty cool. Bunch of cool stuff happening. So go to the Autism Alliance in Michigan website if you can and sign up for our free monthly newsletter. It's free and there's all kinds of stuff going on around the state. And please extract questions from Dr. Allen because this is coming straight from the horse's mouth. How was that? That was a great one.
Thank you.
He's a really good, smart person. Okay.
All right, the decision is to use the speaker or not. Can you hear me okay if I speak at this volume?
Yep.
Okay, then let's just do that. Thanks, everyone. Since we have 2 hours, why don't we, I don't feel like we have to rush through this. If I go straight through the material, it'll take an hour. So I'm going to break at certain points here and open it up for questions, if that's okay. And let me give you just a little more background here on where we're at in this process. As you know, the bills were passed in April, and the bills were signed, I think, mid-April. Actually, I think they passed in March, signed mid-April. And then they go into effect 180 days later, which means they become effective in the middle of October. But here's, throughout the next 2 hours, you're going to keep hearing me say, but remember that your policies may not renew until January. So, you know, you do the open enrollment and you opt into different plans or benefits. They usually start in January. So it's quite possible that you won't be able to show up for your therapies come October 16th and just begin. So that's going to be something you need to check with your insurer and your HR department. So where are we now? I think the day after the signing, we got started on implementation. And let me tell you where I'm coming from. I've spent the past 2 or 3 years participating in the Autism Speaks Law Summit. It comes up once a year. It's a great conference. The Autism Speaks has been around for about 6 years, and this law summit was about implementation strategies or legislation strategies, so getting states to pass their bills. Okay, over time, what's happened is the summit has become a 2-day. One day helping the remaining states, which is 20 now, pass their bills, and the second day, all of the implementation headaches that came once those bills were signed. So we're not going to be the first state to be presented with obstacles around getting services to families, working with insurers, ramping up clinical providers. This has been going on, and what I had hoped to do was take some of the lessons learned from other states and apply them immediately here in Michigan. So my goal was, look, we're going to have open communication with insurers. We're going to find out what the providers are struggling with. Okay, as an example, as a BCBA, how do I get my clinic ready to work with the insurer? How do I bring tutors onto my practice so that I can get family services? So the goal became, all right, we've got this. Now what we want to do is make it a smooth process so that we can get kids served. And you know, for some families, they waited a long, long time for the insurance coverage. So to ask them now to wait even longer will break my heart. So we're working on that. The Alliance has been very busy working with the insurers, with providers. We're doing workshops all over the state, and we have one coming up in Lansing next week. I'm going to give you some resources at the end, so I don't want to jump too far ahead, but you may want to participate in some of these. So that's a little bit more background as to what landed me here today. Before I start, I think what might help guide some of the presentation is for me to know a few things about you. How many of you are parents? Okay, and then are the rest therapists, clinicians of some sort?
Grandparent.
A grandparent, okay. Any educators? Okay, great. Of those that are parents, how many of you have children under 6 or under? Okay, and then how many between 7 and 12? And then 13 to 18. Okay, great, actually great. This is a nice representation across. So, so that helps just as we go through some of the benefit. I'll just briefly, because Dr. Sharp did such a fabulous job of talking about the Alliance, I'm not going to spend a whole lot of time on our history, maybe target just some of our initiatives right now. And then I want to briefly talk about autism. I apologize to those providers in the audience or those parents who actually deserve an honorary degree in autism at this point, because I'm sure you've educated yourself. But to keep in mind with such a diverse audience, we're going to get families that are just learning about this disorder. And then you're going to get those that have been struggling to get information and have been educating themselves all along. So some of this may be basic, but I feel it's important to cover. And then we'll go through some of the bills, the essentials, things you really need to know, and then obstacles and solutions. Okay, so the purpose, just to understand the role of the Alliance, the new insurance laws, what you as a parent needs to know, and what resources are available to you. Okay, briefly on the Alliance, I guess suffice it to say, the one thing we didn't want to be was just another autism organization. That wasn't our goal. What we wanted to do was take existing organizations, whether they be universities, health systems, parent support groups, CMH agencies, freestanding clinics. It really did not matter. Our goal was to identify what is out there, of what's out there, what is good, what is quality, okay, and then help to expand those services or expand that type of quality intervention, for example, outwards, so that we get some of the good stuff going on being replicated across our state. And this came out of really a discussion between two businessmen, pretty influential businessmen with lots of frustration over having to raise their child with autism, one with an adult, one with a teenager, who struggled with finding services and supports, even for people of means. So what did that mean for those who don't have either the level of sophistication, the resources, the financial ability to pay for services? And they decided that they would do something about it. So we created a board. I was one of the founding members of the board representing Henry Ford Health System, and eventually became more of a consultant, and over really the past month now I've moved into the position of CEO full-time, leading Henry Ford, which was not easy. So that's who we are. Our initiatives, let me go back. Briefly, our initiatives, one is this. One is addressing the insurance implementation. The second is our safety. And I don't know, Mary, have there been many trainings out on this side of the state, our safety management risk?
You know, individuals on the spectrum have a 7 times greater likelihood of coming into contact with law enforcement than a typical, you know, the first bump is the wanderers, little kids, and then the next bump is teenagers who say something inappropriate in public or behave peculiarly, and, you know, they push the panic button and then call down, you know, the police come. And, you know, there's many examples of when it has not been handled the way you would like it to have been handled. So we have, in mid-Michigan, 2 of the people on our board had worked very hard to develop this safety presentation in cooperation with Dennis Dubois, who's a national guy whose brother lives in Grand Rapids. And the Autism Alliance said, this is great, let's take it statewide. So police officer, I forgot his rank, Scott Schulke goes around and does presentations with law enforcement about the basics of autism, what you're going to see. You don't have to make a diagnosis, but pretty much the traditional way, sorry, I did talk on it. The traditional ways guys are, the law enforcement are taught to assess things and to handle them are kind of almost the opposite of what you need to do with kids on the spectrum. So we had a certain amount of money budgeted for that, and that was like, every time he does a presentation, there's 3 people in the audience who say, we need you to do that. So anyways, coming soon to a presentation center near you in Grand Rapids, we're working with the Michigan Municipal Risk Management Authority, which is one of the big insurance companies, covers 60% of the jurisdictions in the state, and we're hoping in the fall or maybe early next year to do a presentation to local law enforcement here.
I think they did one with Grand Rapids PD.
Did?
Yeah. I'm sorry, they did one in Grand Rapids PD.
What, was it
then,
recently?
Yeah.
That was Dennis when he was here. That was Dennis when he was here.
Yeah, and then he did one for parents or other workers.
Right.
That's exactly what it is. And I mean, we've really opened up this idea of the safety umbrella to include a number of other audiences. I mean, in healthcare, and we're not talking about autism specialists, we're talking about emergency room staff. You know, and if you followed any of the stories in the media, it really is pretty devastating. These kids are being lasered. What is that?
Tased.
Tased. Okay. But the issue is the behaviors are being misinterpreted as being aggressive or non-compliant. And if you don't understand some basics about what the disorder looks like, the way you respond to it can be very different than what's safe. So we've also included a water safety piece to this and an anti-bullying campaign that we're going to launch underneath this umbrella. So please let us know in your areas. It only takes one parent to call your local law enforcement, to call your transportation department. I mean, bus drivers, if you think about it, I mean, we're working with the YMCA. We just had a conversation with the Henry Ford in Greenfield Village. We have a conversation with the Detroit Zoo, and it's all about, look, we're past setting up autism-specific events. My goal now is to take our persons with autism and those families and integrate them into existing organizations and community functions. It's great that you can do that, go to an autism-friendly park or event. That for some kids that's absolutely necessary, but wouldn't it be great to know that when you go to the zoo, the staff understands autism, the staff is on high alert for wanderers, the staff knows how to respond when a kid starts echoing away and doesn't know what to do. So that's a lot of that initiative, and we've really found so much value in it, and a perfect example of a statewide activity. Okay, so I'm going to just now go through a few basics here. First, I thought it was important to talk about just the management of autism. What do we do with kids when they come in the door? How do we screen for them? Once we identify them, where do we refer them? And then once they get to the specialist, what does that evaluation look like? What are the components that should be included as parents, what you should be looking for? And then once the diagnosis is given, what are the best interventions for children with autism? And then eventually, when they become adults. I'm focused mostly on children because the legislation is covering 18 and under. I'm not going to let Mary talk about what we want to do with adults. I won't get her back. But it's on our radar for those who have children that are reaching upper teens, because there's actually some great activities going around the state related to employment and those types of issues, and we're jumping on the coattails of that. So let's just talk about screening. The American Academy of Pediatrics back in 2007 established some guidelines around screening for autism, which basically dictated use of an autism screening tool, in particular the modified checklist for autism in toddlers. It's called the MCHAT. It covers, I believe, 40 months to 18 or something. And it's a very quick tool. It's a 23 question, yes, no, you fail a certain number of items or certain particular items, you fail. It doesn't mean your child has autism, it just means that testing is being recommended. Many of the kids who fail the MCHAT do not have autism. So that's an important message I worry pediatricians don't get to families, because this is administered for every single child, or should be, at 18 and 24 months. There's some other screening tools that can be used with a little bit of an older child, which are recommended as well. Just because it's recommended even by the AAP doesn't mean it happens. So we will also be addressing early identification and some of the work of the Autism Council. But once the identification is made, this is the big question mark here, because practitioners, depending on their setting, depending on their specialty, refer to different people at different times. You'll get a pediatrician who right off will send that child to early on. And you might get a pediatrician who says, we're going to just send over to neurology. I think there's an autism here. Your other pediatricians might say, this looks like a language delay, we're going to start with speech. You could have a child that doesn't even start with their pediatrician. They just pick up it early on. They call the early on hotline, my child isn't talking, and it gets started in that way. So there's no real systematic way to enter a system when there's a concern. And this is another initiative of ours, which is the Navigator. And I joke about it, but I truly mean we want to establish the 1-800-AUTISM number in the state. So it takes the guesswork out. Okay, you live where? What's your insurance? What school system are you in? Let us hook you up to the right person so you can get started. So there's the referral process that could use work, but generally, when there's a concern, your doctor is going to find a specialist, somebody they know, a neurologist, a psychiatrist, a neuropsychologist, a licensed psychologist. Am I forgetting any of the MDs? Okay. From there's an evaluation. Those evaluations can look different depending on where you go. So when an autism concern comes into the HOPE network, Dr. Krishnan, you get most of those, or all of those, right?
Yeah.
They would be directed to Dr. Krishnan, and I've gotten to know his protocol lately, which is excellent. I created the center at Henry Ford and based that center on principles of comprehensive assessment addressing all aspects of the disorder, which at Henry Ford included a multidisciplinary assessment. Is that always needed for every child? I don't think so. There's some tiered options where maybe you start with one specialist who can identify if there's a medical piece necessary or a genetic piece necessary. So there's some different pieces that can fall into place. And again, it's just not systematic. There's just no, this is what you get when you go for an autism assessment. Depends on your insurance as well. So there's a lot of factors there. But generally what I would look for is a practitioner who has some experience. And your job as parents should be to become very good interviewers for the specialist you choose for your children. You know, you should feel comfortable. And if they have a problem with it, I'd go find another. I'd run as fast as I can. But you should be asking, how many children have you evaluated? How many years experience do you have? Where did you go to school? I mean, that is a perfectly appropriate pre-interview type of step that you should consider taking when you're looking for that person who could potentially give you a life-altering diagnosis. Take it very seriously and do the homework on it. That would be my recommendation there. But you should also look to see if tools are used. So did you walk into the neurologist office and, you know, they watched your child 5-10 minutes, asked you a few questions? Autism. There needs to be a little bit more than that, and we are going to be encouraging that as we go along. There's something to be said for an experienced clinician, but a child in the first 5 to 10 minutes walking into an exam room can look very, very different from what they look like when they step out. So interviewing, collecting multiple sources of information from teachers, from other caregivers, using a standardized tool, and definitely an experienced clinician. Those would be my ingredients for a valid diagnosis. And then the interventions, I'll talk about the ones we hear most about because they've been covered under some plans in the past, or at least for other developmental disorders, would be speech and occupational therapies. And I'm not going to go into those too much. I have a quick slide. And then applied behavior analysis. So how many of you have just heard of ABA? Applied behavior analysis. Okay. All right, so many who haven't, so we're gonna go into some of that. Applied behavior analysis is not necessarily the most well-known approach for treating autism, but currently has the most research that shows it works. And there are, I think it's safe to say, hundreds of different treatment approaches and programs that are out there now. And if any of you have done any kind of an online search for autism approaches or programs, my guess is you know exactly what I'm talking about. So when you look at those, you know, you'll read testimonies about, oh, this approach changed my child's life. The diets have been very popular for a long time now. You know, and a lot of it is parent testimony. There have just not been enough studies with enough children to show that those work such that we can recommend them for every child. That's what you need to keep in mind. So for your child, perhaps you saw an effect. I think it's hard to know where effects come from when you're looking at, you know, a child who gets lots of different treatments and now you've added a diet. But to keep that in mind, that when we talk about evidence-based, we are talking about treatment programs that have been tested on kids who have autism and have been shown to work. Some outcome is defined and shown to have an effect. And currently, we look to ABA for most of those treatments. Now, your speech programs, your occupational therapy programs, some of those programs are supported and fall under evidence-based, some of them do not. Again, it doesn't mean they don't work. There just aren't enough studies yet, quality studies, to show that they can have an effect. So we know speech therapy can be effective for children with autism. They have communication deficits. We know occupational therapy can be effective because they have sensory dysfunctions. So those tend to be the therapies that we think of first: ABA, speech, and OT. So what is ABA? ABA addresses behavior and skill acquisition. What makes it different from some of the others is the intensity, the data collection, the variety of programming, and the levels of program around ABA can really look different. You can have intensive one-on-one with a therapist. You can have a parent training model. You can do consultative work. You can do some group kinds of intervention. So the principles behind it are that you affect change by identifying triggers in the environment, what created the behavior, and how we're responding to the behavior. In terms of skill acquisition, you know, getting a child to learn a new skill. How does that happen? You identify what rewards or reinforcers work for that child, and then you use those to motivate the child to change or use a new behavior. So ABA, we've got lots of resources if you want to spend more time looking at it. And I know Dr. Krishnan has a number of resources as well if you want more information, because we know they offer it at Hope Network. Okay. Some things to look at for a speech language pathologist. You always want to look for the C's after their name. It's Certificate of Clinical Competence. It just means that they've passed their national standards for competence, which is a master's degree in speech and language and 9 months of supervision, working under a certified speech pathologist. Addresses communication, the understanding, the output, okay, receptive and expressive language, social skills, and then how an individual communicates and why they communicate. So even though your higher functioning kids, for example, might have expansive vocabularies, okay, and not necessarily grammatical deficits, for example, or articulation issues, the social aspects of language often need to be addressed in therapy. Okay, so they understand, you know, how to read those cues. All right, I'm looking at all of you right now, and some of you are doing this and really focusing on me. There's others where I'm thinking, okay, not engaged. I'm reading with cues along the way, and it's helping me to adjust what I say to you. And that's what's lost many times in individuals with autism, reading those cues and adjusting your message for the situation. So that's speech and language would address that. Occupational therapy, of course, sensory integration. How many of you have used an occupational therapist at some point? Has it been mainly for sensory integration therapy, or fine motor kinds of, a little bit of both? Okay, so we know that persons with autism can be hypersensitive or hyposensitive to sensory inputs, whether it's auditory or tactile feeling, visual. And what sensory integration therapy does is actually desensitizes the child to tolerate different types of sensory inputs. And then some children have difficulty, fine motor difficulty. They're writing, tying their shoes, handling utensils, and that's more of the traditional picture of OT, is sort of addressing those little motor skills. And you want to look for OTR for an occupational therapist, because I can tell you this is one of those disciplines where you'll find providers who say, we do sensory integration. I would ask, who's doing the sensory integration? Is it a certified occupational therapist, or at least an OTR who's overseeing and developing the program? Any questions so far? This is a good point for questions before I get into specifics of legislation. Yes?
Yeah, how old does the child, I mean, these are, I'm assuming for little kids. We have a son who's in his early 20s, so how far does that go? I mean, my insurance covers him until he's 26.
For the assessment piece or treatment,
Just
or all
for
of it?
treatment for all of that stuff. He's already got a diagnosis and all of that, but just for like some of the other things like social, what age, I guess?
I'll start the response to that, and then I'll direct it to Dr. Christian, but I think he's probably going to say the same thing, which is there's no evidence that it can't work. It's just that, again, from a scientific background, when you look at numbers, the data on the numbers comes in the younger kids. So there are some studies, actually, there's a classic study I've never read, but Dr. Todd from Eastern Michigan always refers to, of a 30-year-old, pretty severely affected, who began an intensive ABA program and made some pretty significant changes. So there is going to be, if you're with a good behavior analyst or a good therapist, you're going to get progress. I mean, you just are. You're going to get progress. It's often defined in what you expect too. What do you expect? If they're nonverbal at 26, are they going to be talking? I don't know. So I don't know if you want to add to that.
That's right. It also depends a lot on for a young adult, what they can do. There are different kinds of therapies that we'd approach at different ages, but we would look both at, can we maximize things that'll keep the person safe and in the community,
Right.
and then also, there is some chance to improve some skills.
Yeah.
And I think most of us would sort of start where we can and see what we can develop, and some young adults are able to acquire significant skills and some have more trouble, but we'll try to make progress wherever they're at.
And I'm really hoping that once we start to get the flood of therapists coming into our state, that we're going to be able to draw more and more of these BCBAs and speech and occupational therapists with autism background that can address some of the older ages. I mean, this is going to drive younger, it just is. But I do think over the next couple of years you're going to see lots of need. I mean, I'm really concerned about those. We're going to get a split is what we're going to get. We're going to get the population that now benefits from this, the early, and then we have the whole population that we missed. And what are we going to do for them? And we're not forgetting about them, but over the next couple of years, the focus on service ramp up is going to be younger. That's my sense. We're going to work on that with the council. There's actually a subcommittee that will begin to address that and has already started. But yeah, functional kinds of activities, personally, I see it. And what does it hurt to try, right? I mean, pick some nice measures, some very specific skills, and you get the right therapist in there, you can see some nice improvements. Yes?
But the legislation only required the insurance companies to cover up to age
Right.
18.
But you know that, right? Okay.
For the ABA, for the autism services.
Just as a minor aside to that, some therapies are probably going to be covered for adults, like primarily the talk or psychotherapy, but everything else is,
And those that are currently covered.
right. Everything that's currently covered continues to be covered for adults.
Yes, over 18.
Is there any definition in the legislation based on severity, or is it all primarily
Nope.
related to age?
Why don't we get right into it? All right, so let's talk about what happened with these bills. Okay, so the original bill that was introduced actually was drafted out of Autism Speaks. They have a, I don't want to say standard bill, but a bill that has been passed in other states. And what happens is you kind of take the prototype, but as it goes state to state, it moves through House, Senate, and eventually gets passed, it looks different. And there are lessons learned in terms of what should go into the bills, what should come out of the bills, so that Michigan's bill was actually an accumulation of experiences from the past 30 states that have passed. Some of the aspects of our bill were very unique to Michigan, which I'm going to highlight, but that's how it started. So this bill started with no caps, no age caps, no dollar caps, no visits caps, so that it would cover whatever amount of ABA you wanted to use, speech therapy, psychiatric care, could go to a licensed psychologist or a physician, no requirement for other testing than that, just that the diagnosis come from a doctor or a psychologist. And so it was a really, really nice bill. Everybody was happy with it. Everyone rallied around the bill. Yes, this is the one we want. Okay, slowly pieces got pulled out of it, and that's how it gets negotiated. There were parts I was really unhappy about, as were many, many families. So for example, the 18 cap, there have been families working on the legislation for 5 and 6 years whose child now is 17, maybe even 18. When that cap hit, it meant all their work to get services for their child was lost, for their child. So in the end there, it actually became a divisive type of a process, because we had all of these families and the support heading into the process, and then we had families that started to work against us. I can't support the bill if it's not going to cover my child. And nobody was happy about it. The consolation on the age cap is that the Federal Care Act removes caps. So again, nobody wants to hear you gotta wait, but in 2014, those will be removed. So it will open up services once 2014 hits, which is all very good news. So that happened. There was a provision to include licensed psychologists as ABA providers. I wasn't thrilled about that, only because I felt it was a gray area, but I really feel that the people who should be providing ABA should be board certified behavior analysts. But what we learned from California, the 29th state, was that there were highly competent licensed psychologists who've been ABA providers for years and years and years in that state, and they got pushed out. And so when Michigan's turn came up, we wanted to open that up so that those highly competent licensed psychologists who are not board certified BCBAs could be providers. Good news on that, it opens up a little bit of access. Bad news on that is we don't really have clear guidelines as to what makes that psychologist competent. It's a little gray. And I'm sure the insurers are going to take care of that to some respect. They'll set up some guidelines. But our concern is you're a licensed psychologist, now you have this whole reimbursement right around this new therapy. And you say, I'm an ABA provider, and you go at it. So where's going to be the oversight? And the insurers are talking about this now. Yeah.
I don't know if you're going to get to this or if you already said it. I don't know. My son sees a OT and a speech therapist, and they don't do ABA. They do developmental or the DIR.
Yeah.
Which I'm sorry, I just found out about this last night, so I don't have like all the terms.
No, I know exactly what you're talking about.
But you know what I'm talking about?
Yeah.
So does this bill make it so I'm going to get that OT and speech therapy covered under what they do, or do they have to do ABA?
Really good question. Can I keep going? Because
Okay.
if I don't answer it, you can start waving and I'm going to go back to it.
Okay.
But it's a great question. So let's make sure we get to it if I don't. I'm pretty sure in the next
Okay.
couple slides. So our final bill, and I believe, yeah, I have the specifics on the bill here. So here's what happened. Here's the basics on the bill. The bills cover Blue Cross Blue Shield, the nonprofit insurers, and then the HMO for for-profit insurers. It includes all insurers covered under our state-regulated laws, and I'm going to break that out in a little bit. Does not include what's called ERISA companies or self-funded companies. I don't want you to worry about that right now because I'm going to talk about it in a little bit so it's clear. It's really important information for you to know. It did not include Medicaid. Did not. And it is limited to services for children medically diagnosed, not children who've been in an educational system with an ASD eligibility even for 10 years. It has to be a medical diagnosis meeting criteria such as licensed physician or psychologist, use of the ADOS, and they have to be evaluated at centers designated by your insurers. So what is covered? ABA, speech, occupational therapy, psychiatric and psychological care. Here's another point you want your highlighter. That is inclusive. That $50,000 from birth to 6 covers all of those. That's not just for ABA. And I point that out because bills in other states have been specific to ABA coverage. Or they'll take it to 35 just for ABA, and then outside speech and OT are covered as well. In our state, it covers everything. So you want to be conscious of that. And what I foresee happening is a lot of discussion between clinicians, and we're already getting this. We've had just a recent case with Hope Network, where here's the benefit, right? Okay, $50,000. So I might choose to use my dollars for psych care, which I don't think includes pharmacy. Pharmacy is separate. Pharmacy is not included in this. But psychiatric care, which can be expensive, and ADA, and I'm not going to pursue speech right now. So that, I'm a little concerned that parents are just going to start picking and choosing. I'd encourage you to work with your clinicians. They should be talking, because you can do, in a nicely coordinated intervention plan, you can have your speech pathologist who consults with your BCBA on specific goals and drives those out in ABA therapy. ABA isn't something separate out here. ABA is going to address communication, social, behavior, tying your shoe, toileting. I mean, it's basically covers most developmental areas. So there will be goals in an ABA plan around communication. Okay, what might be helpful is 2 times a month consultation from a speech pathologist on what some of the communication goals could mean, for example. Or you might have a child who really, do they need the intensity of ABA right now? They want to pursue speech because they found this great speech therapist and the child's making lots of progress on communicative means. So that can happen as well, okay? So there'll be a lot of discussion with clinicians. Parents should have those discussions around what the treatment's going to look like. $50,000 from birth to 6 drops to 40, 7 to 12, 30 from 13 to 18. And why the drop? Because when you look at the research on utilization, generally you get less frequent intervention as a child ages. And it makes sense. What happens at 7? They're in school, right? So you go from 25 to possibly 30 to possibly 40 hours of intensive. By the time they're school age, the goal is to integrate them into school. So it's just what we saw, and I thought it was reasonable, to be honest with you. Questions? I'm going to stop a little more frequently now because it's getting more specific in the back.
Is that's a yearly cap, right? Or is
Yes.
that like,
Not
yeah,
a lifetime.
yearly,
Right.
okay.
That's every year. Is that your question?
No, I just had a question, because as they integrate with the school, I know how important it can be for the collaboration from the ABA, speech to OTs. But I saw on a previous slide that collaboration won't be covered by the bill, so a speech therapist or an ABA, I think the slide said, was to go into the school, that would not be covered through the 40,000. That would be separate?
To have your BCBA actually go into the school? Is that what you're
Yeah,
saying?
like just say have the BCBA go into the school and then do some
And just
training.
collaborate
Because a lot of the kids will probably have paraprofessionals who won't have the same level of training,
Right.
who could probably really benefit from some of that the BCBA
Right.
could provide.
So now's a good place for me to say this. What I'm going to tell you today is what I know. It can change tomorrow. That's how things are working with insurers and providers right now. So this is my understanding today that school will be covered. It will be covered as considered a reimbursable treatment setting. Okay, so yeah, what do you think? It's sort of like throwing them off the bridge. If you've given them 3-4 years of this intensive, wonderful therapy, and now you're going to put them in a classroom. Because we know, with the exception of some school systems and teachers, that the school is not going to be ready for these children. That's our next piece. Once we get all the clinical side done, then we're going after education. But so I just heard that this week, because to be honest with you, I wasn't clear. Like, are they going to cover home? Are they going to cover school? And the answer I got this week was yes. Okay, so yeah, that follow-up, that can happen.
So I guess just one follow-up question then, from a dollar sense, would that be someone going into the school who will be able to utilize dollars to provide services going in like a BCBA? Or will then say the school speech pathologist now be using the dollars for their service?
No, it won't go that way. And I don't know that speech and OT will be covered in the school. I just don't know the answer to that. I don't. That I have not heard before. Currently, for insurance plans that cover speech and OT, you generally are not going to get covered in the school, but that's because the way insurers set up the networks.
Yeah.
So in Medicaid, it works like that in some cases. Medicaid, you actually as a school therapist can bill Medicaid in some cases. But what I heard this week related pretty specifically to ABA in the schools. So I just don't know the answer to that, but I don't think a clinical speech pathologist who say works at Hope Network goes and provides services in the school that she or he would get reimbursed.
Yeah.
An ABA therapist could. Mary, can you write a couple questions down? That's the other, this is the goal for me in these meetings, is to get your questions, because then I can take those back to the insurers and ask some of this, because that's a great, like, why the discrepancy? And you can come back. I'm afraid to ask, because I'm just so happy that they decided to do schools for ABA. And I left the ball. We're not going to do anything. Yes. Do you have a question?
I do. Will there be a definition of school?
Question number 2.
Type of school, center-based versus gen ed?
I think if I understand the question correctly, what Dr. Allen is saying is that a healthcare provider, like from Henry Ford or from us or something like that, can deliver services off-site to your child, like at the school or at your home or so forth under the legislation. But it's really the healthcare provider going to that site to provide the service. So I don't think it matters so much what the definition of school is. The point is the healthcare provider can provide the service off-site.
I know you say that, but I've had billing issues with type of setting before. I'm just thinking out loud.
It's a good question, yeah.
Yeah, I think for the 3rd time tonight, I'm going to say, check with your insurer,
Right.
honestly.
Right.
And, you know, I got some great advice at this law summit last year, which was when you find that one person at the insurance company who will listen to you and appears somewhat helpful, you should become quick friends. Get their direct line, somebody, because it will make all the difference in the world. Where your tendency is to explode the minute they answer the phone after you've been waiting for hours, to make friends, because it's going to be a lot easier to get your questions answered. And our website, we hope will answer, like these questions are going to go up and we're going to have answers to them. So I'll, again, refer you to it, but it's going to be where to go for updated information. It's up and ready, and we've already started putting, all of this is on there. These PowerPoints are on there, and your questions will go on as well. Yeah.
I know hindsight's 20/20, but down the road, at least in the immediate path, being a public educator, do you see some of the districts due to the financial stresses that they are enduring, and they see this bill, that they might start backtracking with some services?
No. Like, oh, they're getting clinical therapies outside, we're not gonna worry about speech? Is that what you're asking?
Yeah, I mean, in a way.
I don't think there will be
not-
anything in terms of policy, but that may be unconsciously what they're thinking, which is, all right, I can't get to that kid this week. But they get speech outside. They can go 2-3 times a week for their speech. I mean, I suppose it could happen.
There's such a shortage
I know there is.
right now that they're starting to hire, they're resourcing it out, and if, they can cut.
Again, there's exceptions, but generally, this is why this legislation is going to be so important. And I know the school is a different setting, and school-based speech services can look really different from clinical, and it's a different setting. But at least this is something, because to be honest, of the districts I know, they might as well not be going at all. They're going in groups, and they might be getting 30 minutes a week, and it's basically to meet the IEP standards, and it's unfortunate. But lucky for all of you who have kids in early education, not so lucky for our Lieutenant Governor, who's struggling with a lot of issues with his own daughter. But his struggles now with education, she's ready to enter school. He's ready. He's going after them. So those kinds of things really drive policy. And as you know, personal experiences by people who are influential can really create change, and we've already seen that. So more to come. More to come. Did you want to add anything, Mary? No? Okay. So let's go back a little bit. Now, who can provide care under the legislation? And now I am only talking about evaluation and diagnosing. Getting your child that 299. 299 is the autism code, diagnostic code for autism. And that includes classic autism, PDD, or Asperger's. Spectrum, the whole spectrum. It often looks like 299.3, 299.0. But it should start with the 299 for coverage.
My son has been diagnosed with the Asperger's and PDD, and I live in Muskegon, and it took me 3 years to get someone to listen to me. I had to do my own research to something's not right with this kid, something's not right with this kid. He went through trouble all through junior high school. No one listened to me until, like, one teacher, my daughter and my son have 2 different last names, and when I went to the conference, she been connected to until she saw me. And she's like, wait a minute, something's not right. It took one teacher to, the doctor didn't listen to me, the teachers, the counselors, no one listened to me. And now I'm sorry to change the subject, but I came to see if there's anything in Muskegon. I mean, I'll travel back and forth, but.
You're going to see ramp up, I think, from Hope Network. Muskegon is what from here, like half an hour or so? You're going to there's going to be a natural progression for services. It just is. We've been depleted because it hasn't been paid for. So the only providers out there are those that could extract dollars from the private payers, which is few in number. So now we have a whole new structure in place. It's not perfect. There will be co-pays. There will be deductibles. It will be treated like any other insurance. But it's going to start drawing, for example, the ABA therapist, the board certified, we've already jumped almost by 10. Just since legislation was even the thought of passing it. So our graduates who have routinely left the state because they can't get jobs are starting to slowly come back. So it takes some time, but you're going to start to see more and more services. The CMHs are going to start to grow. We just had a fabulous meeting this morning about some of the plans to build capacity in our community mental health clinics with the Medicaid benefit. So, yeah, I know that area is depleted.
Because he didn't have Medicaid, because I do have Blue Cross Blue Shield, and they went in to see us at CMH.
Yeah, they won't. Typically, it's one or the other. Okay, but the important thing to remember there is that, again, the teacher might have picked it up, but that is not going to be enough to submit an insurance claim for therapies. So, again, here's my emphasis on checking with your insurer, because what I'm learning is that the requirement for a licensed psychologist or physician, the requirement that the ADOS be administered, is not going to be enough for some insurers. They are going to insist you go to the centers that they designate. And that's important for you to know. So you may have a fabulous psychologist that you have worked with for years, okay? But if that psychologist is not in their network or part of a center that they've established, there's the potential that it won't get paid. That's what I know today. That could change tomorrow. There's actually a lot of discussion about that right now. Okay? On therapies, the speech pathologist needs to be certified, the OT needs certification, psychological care has to come from a fully licensed psychologist or an LLP, which is a psychologist that works under a licensed psychologist. And then ABA therapy, they have to be board certified behavior analyst or a licensed psychologist who meets certain requirements. Again, insurers. Confirm, this is again, we're still talking diagnosis, confirm with your insurer that all criteria are met, nothing more is needed. Make sure that your child has the diagnostic code 299. If your child has been evaluated in the last 3 years, you should look for the documentation of the diagnosis of autism and whether that was given by a physician or a psychologist. Because currently, today, right now, we still don't have a definite answer on the children who are evaluated in the last 3 years. Because we have a twofold issue right now, which is what do you do with all of them that have been evaluated previously? Do they have to go through all the requirements? And what are we going to do moving forward? So the insurers are working through this right now. Okay, some are going to set looser standards, possibly, going retroactively, which is, hey, you know, if they can bring us or give us documentation that the child was evaluated, you know, within 3 years by a licensed psychologist in our network, a standardized tool was used, we're going to give them a pass. Maybe. Okay, that it's yet to be determined. Again, our website will give you the updates on those decisions. There's a question over here.
The physician that has to do the diagnosis, does that have to be, can it be just my son's pediatrician, or does it have to be something special that the insurance company tells me to go to?
Yes. The majority of pediatricians should not be diagnosing autism. Pediatricians should be sending you to an autism specialist, a psychiatrist, psychologist, neurologist, neuropsychologist.
You know, most of them are just in denial. Like,
I know they are.
They just don't even, you know, oh, you know, whatever. I do everything myself. I tell the pediatrician
what you need.
What, I know what, yeah. And I tell
That's
them,
why, and the insurers are not blind to that. The insurers know that families will go to a practitioner and say, I need the therapy, can you just write the diagnosis?
That's what I did.
Oh, here's the ADOS from our school. Our school administered the ADOS, here's the results. Now I met the 2 requirements. Can you sign off and send? They know that can happen. It has happened for other conditions. So that's why the guidelines, you're gonna hate them, but you're gonna love them too. And my feeling is always been, if you get it wrong from the beginning, you're going to get it wrong for potentially years out. So getting that diagnosis right from the beginning determines what therapies are going to be best. And that's where you're going to get your outcomes. I mean, we've had a lot of kids in the past at Henry Ford where they were ready to start their ABA treatments, and really for that child, it was a speech-language issue, not an autism. Pour your dollars into speech-language therapy, you may get more out of it. So that piece of it really is important. So I appreciate their efforts on tightening that up, but my concern, and Dr. Christian and I have had lots of conversations about this and will continue, is the access. So, you know, the centers that meet all their requirements, to be honest, they're on the east side of the state.
The centers are on the east side of the state. So can I go to the center just to get the diagnosis and then come back
Oh,
here and do all
absolutely.
my other stuff that I've already been doing?
Absolutely.
Hope to get some coverage.
So there's no
Absolutely.
center in the West Michigan area that can diagnose.
We're working on hope. We're working on hope.
What about brains?
Well, I was say something, so my son got his diagnosis from
It's all insurer dependent. I'm not the bad guy here, I'm just the messenger.
Well,
That's why I keep saying, check with them, check with them, check with them, because initially it sounded great in the bill. Okay, licensed psychologist or physician, right? They'll use the ADOS, so they can go out and get trained on the ADOS. But there's another paragraph, I wish I had a bill handy, that they fought for, the insurers fought for, which was that they reserve the right to set up networks and centers. And in doing that, I don't want to say trumped the other provision, but made it more difficult. And they can do that, they have a right. And again, I want to go on record, much of that I agree with, because I firmly believe we need to get it right, and there are a lot of children misdiagnosed. One way or the other, like don't have autism diagnosed as autism, have autism diagnosed with something else. So that starts the process. Yes.
Can you talk more about the access requirements? Because, we've been working with our insurer, and it's very clear to us that they only cover in-network. And in-network coverage in this area, I kind of touched on it, but it's bleak.
Yeah.
And that in some ways it feels like a potential end route around the legislation if they don't have a network. And I mean,
Right. And that's one way to look at it, which is if you limit access, you limit claims, and it doesn't cost as much. Which is a little ridiculous because the state is paying for it. But I mean, I think they're thinking longer term. And I don't really believe anymore. I mean, I really think they want to work with us, to be honest. If you had asked me 6 months ago, I said, oh, yes, definitely, they're the bad guys. And because we had all of these discussions before the bills went through, but they really do want to try and make this work. And they are working very hard to figure it out, just like we are. They want to provide good therapists on this side of the state, but they also, and you are going to want them to make sure that that therapist sitting in a room alone with your kid knows what they're doing. It's a safe situation. I mean, some of this oversight is really, really important. Basic safety and progress. You should be able to require 3 and 6 month out progress notes and clearly track your child making progress with a good therapist. Because they're that good. They'll make adjustments so that progress can be made. And who's going to oversee that? We have to rely on someone to do that, and that is the insurer. So try to be understanding about their process, and we're really working. The Alliance is working so hard. We're working with universities to include students as line therapists. We're trying to collaborate with the CMHs. They have a network of providers already. What can we get them so that they can become line therapists? So we're working really hard on that. And you can follow our workshops, our provider workshops. You'll get a lot of information, actually.
so about the access requirements, what can we expect? What's our recourse, or is that?
It'll be dependent on your insurance.
Right.
And if your insurance company doesn't know the answers yet, it's because they don't know the answers
Right.
yet. But they're still going to have to develop an answer for you.
But I will tell you this, your ammunition, come January, and there is not a single solitary center or organization where you can go and get that medical diagnosis. You have a legitimate complaint, I would think, to Insurance Commission in our state, which is called what? OFR? Terry, is it like Office of something, Insurance Regulation? But that's the way you do it. I mean, you can voice a complaint and they would look into it, but I don't know the specifics. That would be my first thought. Yeah.
I have to bust up a little bit, honey, because I'm confused. So we need a diagnostic evaluation from a licensed
Psychologist or physician.
psychologist or physician. And so if our children are already going to a licensed one, we're okay, or do they have to go through, because my daughter was, she's going to one now, and I have an HMO. Is this going to change what she's doing, who she's going to, or do she need
It may or may not.
to be evaluated because she's older, she's 17, and
Again, that will depend on your insurance company and whether they will allow that provider to continue to participate, or whether they say, oh, well, we don't have that provider in our network, but you will be able to find equivalent services in this group that we do have a contract with. So if we don't have a specific answer, your insurance company should have the specific answer, and they may not have it yet.
But let me back you up real quick before you go on. So is she seeing the psychologist regularly? Like she goes for some kind of counseling or care from this
yes,
person?
every 3 to 6 months.
Okay.
She's been doing that for years,
Okay,
for
so-
several years now.
So
yes.
in that situation, it's very likely they're not going to kick that person out of their network. I mean, it's a recognized psychologist who's been providing care. They will likely keep that person in to provide autism-related care, except for diagnosis. This is the new criteria, which is if that was the psychologist who gave her a diagnosis of autism,
No, it wasn't.
Okay.
That's the problem.
then you are likely going to have to take her for a reevaluation if it's been more than 3 years. As a general rule, if it's been more than 3 years, I would get on the phone and find out who administers the AAoS and whether it's a licensed psychologist or psychiatrist, because the wait lists are going to grow. I would be doing that. I'd check with insurers, can I go to this place? And then I would call and I'd say, okay, who gives a diagnosis here? Do they use a standardized tool, in particular the AAoS? Even that's a little sketchy right now.
I just wanted to add, she said her daughter is 17 and we're having a similar situation with my child also. My son was actually diagnosed out of Cleveland Clinic because our neurologist sent us there. So, for other issues with epilepsy. So it was all kind of tied together. Before your daughter turns 18, you will have to have this testing done again for any insurance on her own. When she goes to, to that adult world, she'll have to have the
Yeah, because I've
testing.
been kind of trying to deal with Hope Network. Y'all getting on my last nerves, really. But anyway, trust me. Okay, so it'll have to be
But
done.
psychological testing has to be done before the age of 18 for any type of disability, if she would to get disability, that would have to be done before.
Yeah, and just so we can move on a little bit, but I would encourage you to, like I said, when was the last time your child was diagnosed? And the fact is, it's really best practice every 3 years. Don't you want your child reevaluated after 3 years? I mean, I would think you would. I've spent 3 years in speech and OT, and what kind of progress is it? I mean, it really dictates what happens over time, and that was built into the law, that they would be reevaluated every 3 years, and I do agree with that one. That's some good practice there. Okay, so let's move along a little bit. I apologize for being non-specific around diagnosis. Truly, this is changing day to day. So you should, again, our website will have updates, and I'm giving these workshops all over the state. Dr. Sharp's going to start stepping in and doing some, and one of our other staff. But each workshop brings new information, to be honest, because your questions, I'll try and get some answers to, and those will be incorporated into the next one. So it's worth following some of what we're learning. Yeah.
I just had a quick question, talking about the centers, and you were speaking about the insurance companies. Is this a hope that the insurance companies will have the same criteria for centers and just all have the same centers? Or will Blue Cross's centers be separate from Aetna, which is separate from Priority Health? Do you have any idea?
There's going to be overlap. There has to be, because there's not enough providers.
They're each kind of going about making their own decision. Okay, I didn't know if
They
they
do financial negotiations.
Yes.
Yeah,
So
I know
they're
that.
all in a different game. What they want to do is get a cheaper price than, those people got,
Yeah.
which is the cynical side.
Yeah, and so, I mean, depends on where you go. The larger, the U of M's, the Henry Fords, the Beaumonts,
Yeah, all
they
the
take
companies,
lots of different insurers. So some of them are going to be very specific. I do know that. You've got this HMO, you're using that system and only that system. Others are going to open it up. The ones that are, we want them flexible. and most are recognizing there will be a shortage. And that's an opportunity to open up that network to lots of different people because there's none to begin with. But over time, they'll start to weed out those that are higher quality, they stay in the network, those that shouldn't have been in to begin with. Okay, let me just move on.
Can I just clarify
Uh-huh.
one thing? You know, a diagnosis and an evaluation can be different processes. And theoretically, you only need to get diagnosed once because autism is something that is not cured. It is a lifelong condition. But evaluation to see what kind of progress is being made is what we should all do with any therapeutic course. You know, you don't stay in physical therapy for your bum knee for 10 years. I don't want to pay for that if you're in my insurance company. But so an evaluation for update to get established goals. And so the ADOS was selected because it's a commonly accepted measure.
It's considered the gold standard in diagnosing autism. But it's only the gold standard if there's an experienced clinician doing the rating on the ADOS.
And then the other part is that if your symptoms if your management and you have a full life and you're functioning in multiple areas well, then those subsequent evaluations, I think the legislators were concerned that they wanted to make sure people still qualified for needing this help because of the huge population of neurotic people who want to keep going to therapists for conditions that they've already cured of. That was my second cynical comment. See, I'm the cynic and she's the optimist. But so that the ADOS, that every 3 years, I would think you'd want an evaluation of your program and have it corrected to do a little more of this and a little less of that more frequently than every 3 years. But that was put into the legislation to stop exploitation from all those healthy people who are seeking services through their insurance company.
Okay.
Can you tell me what AAoS would be?
It's the Autism Diagnostic Observation Schedule. And it was developed by Catherine Lord, who actually just left the University of Michigan. It's a very well-researched tool. It's an observation tool. It's not a parent checklist. You actually have to observe the child. There's different levels depending on the functioning of the individual.
What's the F?
Schedule.
Okay, thank you.
Sure. Another question?
Is there going to be a cap on the spectrum, like lower level versus high level? My child's very high level, high functioning.
Only the cap that comes with the age.
Just the age.
Yeah.
So even if it's high functioning.
If he's got the diagnosis.
But like the school systems can determine that you no longer qualify for services. Of course, the irony with that is that if you have a child with Asperger's and they're very bright and they're doing well in school, they still need the social coaching. That's essential, but that's sort of been an invisible service entity up until now. You know, we're just coming into the modern age.
Okay.
I have a real quick follow-up on that. Well, this is really maybe off topic, somebody brought it up a little bit. Is autism considered a disability to where we can apply for disability at some point in his life?
Oh, yeah.
Is it? Oh, yes.
And that was the 18-year-old.
He can apply for disability.
Well, but let me just qualify.
Who's gonna, assess that?
The community mental health system has criteria that does not necessarily mirror medical criteria, that does not necessarily mirror educational criteria. So you can have a child who, just as an example, meets educational eligibility for autism spectrum disorder, sees a medical team, and they decide he doesn't get the diagnosis, okay? Or vice versa. You can enter CMH, you say you have Medicaid and you're going now to tap into services. They have a different criteria, not so much criteria, but eligibility requirements than even what a medical team might have.
What's that CHA that you're talking about? What is that?
That's community mental health.
But also, your disability will come from the Department of Social Security. And so Social Security disability is a whole world unto itself. But usually if you've been working with a psychologist regularly, who deals with people with severe disability, they will know how to fill out the form that is required by the by the Social Security Administration.
Team help me when he's in high school.
They will. How old is he now?
He's 9.
All right, Mary, by then, we're gonna have it down.
It'll be seamless. It's going to be so cool by the time
He's
he's
gonna tell me
18.
what to do.
It's good, yes,
I'm
yes.
gonna be the one at the problem. You'll be
I
okay.
have a question going on with that because CMH won't see my son. They told me they can't see him.
Well, it depends on the CMA. Some take private insurance, some don't.
That's my thought.
Yeah, they have to take Medicaid. They don't have to take private insurance, I think.
Because I have, because the children had to come all the way over here to.
Yeah. Yeah.
Well, if your child meets a certain severity, you can apply for Medicaid waiver through CMH too, but that would be a more severe level of autism.
Right.
Well,
That that would be an access to CMH services, where your income doesn't count or your
Right.
private
It's a
insurance.
small percentage of who they serve, but that is true.
Yeah,
452 Medicaid waivers.
but it's there for
It's
severe,
there.
Those are your site
important to know about.
Well, theoretically, they're supposed to be determined by severity. More often, it has to do with the pool that's applying if a waiver becomes available.
Yeah.
That was my other civil. Should I just shut up now?
It's all, you're good. Okay, so let's just move along. Things you need to know about therapies. Michigan just doesn't have enough. We don't have enough service providers right now. We're working on it, but we're in the process of ramp up. Other states have taken 3 to 5 years for supply to meet demand. So enough therapists to meet the needs of children. It's going to be frustrating. We're working aggressively to make that, to minimize that. And my goal is 2 to 3 years versus 3 to 5. I'm not going to spend time on this slide. It's there for you to look at, how we define what's evidence-based. Because a lot of you might have questions about, well, what about music therapy? Okay, is that going to be covered? Or interactive metronome, is that going to be covered? There's a lot of therapies out there that it's not to say don't work, they just don't have enough research to show that they work yet. So now I can take the question about DIR, which is developmental interaction relation.
Individualized relationship.
Yeah, it's based a lot, well, the Play Project and Floor Time are based a lot on the DIR model. So is that going to be covered? I can tell you that a great tool for you to look at that the insurers are going to be using, the providers are going to be using is the National Standards Project. It has become somewhat of the Bible. It's not perfect, but for identifying what gets covered and what doesn't get covered. And just briefly, the references in your resources in the PowerPoint. What this document has done is it's taken many experts in our field, and what they did is they looked at the research. And they looked at the research that supports different kinds of treatments. And then they categorized them into 4 different levels. So the first level are those that are called established. They have, based on what the scientific panel decided, enough research that shows they work. So they're established. The second group is emerging, which is a number of treatments where DIR falls that have some research, but not enough to put them in established. We're not saying they don't work, we're saying there's not enough. And then we have the third category, which is non-established, I think, and then the last category is ineffective or harmful. And there's a few in there. So, maybe 3, really. So you have these, and this is what's going to be used, this and a couple other documents to determine actually which claims get paid. So, in response to your question, that may get paid. It's not for sure. It's considered developmental. There's some developmental research in emerging. It comes under another category, not DIR. But really what's going to trigger payment is going to be, first and foremost, the credentials. So ABA If that claim is submitted under a BCBA, it's likely to get covered, okay? If that claim is submitted under speech, it's likely to get covered. Now, the insurers may impose some standards there and say, look, well, for one, facilitated communication provided by an SLP, huge, huge red flag. They're not going to pay that out. That's an ineffective and harmful, I believe. So there will be some oversight. It hasn't been totally defined, but that is the tool. That is a great, great document and is written for parents to understand. National Standards Project, if you just do a Google search. It is in our resources at the end here. But it'll break all that down.
On this slide, you're also talking about medications that may be effective for challenging. Is there, it's the top, it also says number of expert panels, task forces, and reports reviewing the research agree on the following points. Does that mean that there is a list of agreeable medications? If they're effective, they're covered?
There's I think only 2 covered specifically for autism, but we know there's a number of medications to cover behavior in general. So if it's an intentional issue or an aggressive issue, there may be a medication, and Dr. Christian knows this better than I do, that targets a particular behavior, even though it hasn't necessarily been approved by the FDA specifically for autism. There's 2 for autism. I can't remember what they are. But yeah, an MD would determine that. Did I answer your
Determine
question?
whether or not they could be covered?
No, we'll determine which medication is best.
Okay.
Generally, if it's been covered now, that's not going to go away. Okay, if your child's on a medication now, it's going to get approved. It's going to get paid.
The evidence base in pharmacology with children is very complicated because it's difficult to do the kind of studies and documentation that you need. And so many of the medications that are used regularly are full of qualifications. If clinical judgment determines that this justifies the potential risk, so that's how the drug companies protect themselves. And there just has not been a huge, like if you've got heart disease and it's your cholesterol, man, that stuff's so easy to test and so easy to sell. But this area in particular, there's so many ethical questions about.
Right.
And also there hasn't been, we've marginalized so that there's 2 systems. If you're physically ill, you have your appendix out, we're gonna pay you a lot of money, but if you have mental illness, that's like character driven and clearly you weren't parented right and you are a bad person. We've had that division traditionally, and the whole thing about the mind-body connection is, as the science improves, your microbiology, your electron microscopy, neurotransmitters, that's a whole kind of way of looking at physiology that didn't exist as our insurance systems. Classic genetic bipolar disease is as physiologic as emphysema is, but we still have there's still been this traditional split between covering services for psychiatric disease.
Thanks, Mary. We talked about this. How are insurers going to know what should be covered and what shouldn't? Right away, provider qualifications will be a trigger. So when a claim comes in for an ABA service and it was provided by someone who is not a BCBA, it'll be rejected. Again, as an example, facilitated communication, music therapy, those will be triggers. Their systems they're working to get their systems to identify those and reject if they don't meet these guidelines. I mean, they're really, I'm telling you, every day going through, rereading the legislation. Here's what's covered, here's what's not. Here's who can provide the service, here's who can't. So it's being read line by line, and their systems are being set up to recognize the law. There's a number of organizations you can look to. This was the slide I was referring to that will put information out about evidence-based treatments. And this is on our website, so you're welcome to put it on your site too if you'd like, Dr. Christian. I already mentioned this, alternative and non-conventional are not going to be covered. So diet, supplements, the hyperbaric chambers, listening, recreational therapies. which I love recreational therapies that just aren't considered evidence-based. And to be honest, I don't think I would consider those medically necessary and appropriate for clinical reimbursement. Okay, Medicaid briefly, because this is fairly new information. I said that Medicaid was not covered in the legislation, but Medicaid was passed in our state's budget just a few weeks ago, which is fabulous, at $20 million. The one thing I didn't talk about was the appropriations bill. So the difference with our bill compared to others, not Medicaid, our standard bills, is that really the state set aside money to pay out. So in other states, the insurers would pay out the claims. Now, the insurer is going to take that claim and they're just going to submit it to the state, and they'll get paid. So the insurers provide the oversight, they identify the providers, they get the claims, and the state pays them. Okay, there was $15 million set aside for that purpose, to cover our kids. The 20 is for the Medicaid and the My Child. Leaving, and the coverage here closely mirrors the autism bills, but the specifics really are not out for the public to view as far as I know yet. Okay, but they're pretty close in terms of speech and OT and ABA services.
Will that follow that same age guideline?
Yep. Actually, I don't know. I know it's
Because
under
Medicaid
18.
services go.
Yeah, good question. I don't know. I don't know the age guidelines. Question number 3. I'll try to find out. I know the difference with the Medicaid too is the waiver system. Yeah. I believe this is going to be set up as like an autism waiver in our state. So my guess is that's where those caps are going to start kicking in. So you get a certain amount under certain waivers, and it's going to be designed that way. My understanding of it. I wouldn't write that in stone. We will check on it. Okay, a couple of things here, because I really need a few minutes to help you understand self-funded companies and state-regulated companies. We talked about a lot of this, just some of the obstacles, the diagnostic crunch, I'm worried about it. We talked about access issues. I would get on it now. Just look at what you've done with your child over the past 3 years. Begin to look at where they were evaluated, and check with your insurer. Obstacle 2, lack of qualified therapists. I'd be calling ABA centers right now. Find out where they're at. You can go to BAAM, Behavioral Analysis Association of Michigan, and I would find every therapist who works in autism. We're trying to do that too, actually. We're going to get them on our site, identify who out of the 100 in our state serve autism. I get on a wait list with them. And here's what you do when you generate a wait list. You generate demand for the health system or the clinic to hire. So they can go back and say, look, oh my gosh, by January, we've got a wait list of 50 children who need ABA. We're going to need 3 or 4 BCBAs or whatever. And it just justifies the hiring, because as we all know, there's not a lot of hiring going on anywhere right now. But those wait lists can be an important incentive. We're working with the universities. Universities are working with the clinics. And then, for a while here, there will be less intensive models that get implemented, and it's to get the services to families. So it may be an ABA parent training model, and there's at least one, Project Impact, which is Brooke Ingersoll's work. So that's ABA based, a real effective program, follows quite a bit of the developmental principles. So addresses a lot of that joint attention, social communication piece. But there will definitely be some attention to those kinds of treatments early on, just to meet the need. And then working with insurers, we're doing that, hopefully doing that for you. But on your own, you want to make sure you make that contact at your company, call frequently, ask lots of questions. Okay, this is an important point. I think probably the most important of the entire night. Another exclusion from the legislation was for what we call ERISA, and I don't know what the acronym is, but businesses are insured from one or two different avenues. One of them is that they're federally regulated. So federally, they're told what kind of benefits minimally they have to provide. And then you have state regulated plans where the state decides. So our legislation was for Michigan, right? State. So if the business is state regulated, you are good. If you are employed or your spouse is employed by a self-insured / ERISA company, you are not covered. And 75% of Michigan businesses are ERISA companies. That's why I'm telling you this now. It's important you know the difference, because you could conceivably, I don't really think this is going to happen, but you could go along, come January, think we're good, we got the autism coverage, and find out your husband or your wife works for a self-insured company. The self-insured company has to adopt. They have to make that step. They have to contact their HR managers and say, we need to add the autism benefit and make it available. There is currently no reason why they shouldn't do that. Okay, there's lots of reasons why they shouldn't do it if they got to pay for it. So all of the other states before us are having this real issue. This is a whole nother section of Autism Speaks. How do we get to the ERISA companies? So what you'll have is a company that just buys the benefits. If they're big enough, for example, tends to be the larger companies because they spread the risk if there's more numbers. So they self-adopt and they say, we're just going to pay for this benefit because it's cheaper for us to do that than to go through the insurer. Okay. There's in the states that, in non-Michigan states, so every other state in our nation that's passed the bills, if your spouse works for an ERISA company, you're not going to get an autism benefit unless they choose to adopt it. Currently in Michigan, there's only one company that is self-adopted, and that's DTE. So if you're a DTE employee, you have an autism benefit. And it's a pretty good one. It doesn't have any caps. It's a really, really good one. It's one to model after over time. However, in Michigan, the self-funded companies get to tap the fund. They have no reason not to do this. So if you find out that your spouse works for a self-insured or ERISA company, you want to get on it. Or you want to contact us and we're going to help you to get on it because they need to adopt. And they can do that. They don't have to pay. They're not on the hook. They can do it. Okay? It's easy, unlike other states where you got to fight with them about, look, it's not going to cost you that much. You're going to have better productivity. Your employees are going to be happier. You're going to be looked at as a more desirable company because you address autism and your families will be happy. We don't even have to worry about that. So next Monday, the Lieutenant Governor and Dave Meter, who's the CFO from DTE, and myself will present to ERISA managers, okay, the ones we were able to reach. Because interestingly, there's no way to find which companies are ERISA and which are not. In our state or any state, you can for a small price of a couple $1,000s, but those lists are, for whatever reasons, top secret. So we're working to get those lists posted. Actually, the insurers have been pretty helpful in this regard because they know who they are. So we're working with them to get that out so families know. Are there questions about that? Okay, because it's not going to be easy to find out. You can try calling your HR department. You can call your insurer, and what they'll do is they'll plug in your contract number, and typically the first 3 letters on your card triggers whether it's self-insured or not. It's not always the case, but it's good information to find out soon, because you're gonna want to work with us to get your company to adopt.
Just to be really clear about that, can you explain, like, if you were the parent, how would you ask that question?
I would just call and just ask, is our company a self-insured company? That's the question. Good idea on simplifying that. It's a lot of information. Is it a self-insured? A follow-up question might be, is there a state plan that I can choose, because to make this more confusing, the bigger companies like the universities, they'll actually offer both. They'll be self-insured, but they'll have one state plan. It tends to be the HMO. Okay, so for example, at Wayne State, they offer Blue Cross, they offer HAP, they offer health care or something. Some of those are state regulated, some of those are federally regulated. But I think the simple question, the other thing that's going to help you is when you go to open enrollment, you're going to see, BCN or priority. They're going to list out in your open enrollment packet autism. And then the Blue Cross option may not have it. So you just need to be conscious of that. Don't make the assumption I'm good if the laws were passed and everybody's covered, because that's just not the case. Okay, I'm at the end. Wow, okay, 20 minutes. I think I'm at the end here. Yep. And then we have a number of resources, some through the Alliance. Our emails are down at the bottom here. Our website. The Insurance Collaborative, this first site, is our brand new portal to get information to families. And then just some resources. So I'm open for questions and discussion.
Was there a paper copy of these resources?
I don't think so.
Available?
You didn't do a paper copy, did you? It's on your site, or our site.
Okay. Can you give your site again? It went too fast. Your website.
It's very easy, just very long. It's www.Autism Alliance of Michigan, the entire thing written out, .org.
You mentioned there may be possibility of treatment for those who are result of this study. Is there any evidence as to treatment for those more senior?
Yeah, we talked a little bit about this at the beginning. Yes, there is some research. There's just nowhere near as much as there is for the younger children. So it's a great.
I'm not talking about children. I'm talking about
Yes.
senior adults.
Yes, yeah. So yes, there is some research that has shown that when you take an adult, even an older adult, and you introduce an intensive therapy program, that they can make gains. What we don't know is who could make gains, what are the characteristics of that person, what is the functioning level that predicts who's going to make progress and who doesn't. So there's less research for those older groups than we have for younger. So the answer to that is yes, but it's minimal.
When the age cap disappeared in 2014, is that also applied to Medicare?
I believe it does. My understanding is the healthcare law, there's no caps across the board.
I had a question. When the bill was being introduced, was it talked, I mean, I know it goes to 18, but with school-age children, especially here in Michigan, going to the age of 26, was that looked at that time? Because most insurance companies cap that a parent can, insure them past 26. In Michigan, we have the luxury that our children can go to school till age 26. It just seems like that would have been a more logical number.
Please, honey, logic has nothing to do with any of this.
She took the words right out of my mouth.
Yeah.
Don't go getting rationalized.
To be honest, I mean, I don't know who our legislatures get some of their information from when decisions are made. Like the ADOS, that honestly, that came out of nowhere. And it was truly, make a decision now. This is what they're proposing. They want this tool. Someone fed them that information. And again, if I have to pick a tool, I'd do the ADOS. But it's not just about the ADOS. It's about knowing how to score that tool, which worries me. So, it takes some clinical judgment to use it even. But it got to, we can do this and agree to it, or we're not going to get a bill. That's what happened with 18. They wanted 18. It was a way to contain cost. They didn't feel like there was enough research to support the older ages. They cut it at 18. It's just, again, that's the negotiations that happen. I've never in my life been involved in politics before this, and it was definitely an eye-opener.
There was
How
very
things happen.
moneyed opposition to this legislation. Even given the simple equation, overall lifetime costs for an individual on the spectrum, $3.7 million. With early intervention, half of your population will be able to enter mainstream, regular gen ed without additional supports, and then 40% of the remaining will improve. So that's a pretty good equation, right?
Yeah.
You got a taxpayer, or you got somebody who's, you know, like my son, who's sucking down his SSI and eating all the chicken nuggets he can with it.
Okay, any other questions? Thank you, especially for being late on a Monday. Got the whole week ahead.